My name is Paulina Vega. I'm currently from University of Texas, Rio Grande Valley, right in South Texas. And I'll be presenting a case of a dangerous complication of acute pancreatitis, abdominal compartment syndrome. Abdominal compartment syndrome is defined by increased intra-abdominal pressure of more than 20 millimeters of mercury, and it's associated with the new organ dysfunction. The mortality rate is reported to be approximately 50%, even with surgical abdominal decompression. If not treated promptly, it can be fatal in less than 24 hours. Pancreatitis is a well-known risk factor for abdominal compartment syndrome and is associated with increased mortality and morbidity. I'm going to be describing a COVID-19 positive patient with recurrent acute pancreatitis secondary to hypertriglyceridemia who developed abdominal compartment syndrome. And my case is a 34-year female with history of recurrent episodes of hypertriglyceridemia-induced acute pancreatitis who presents to the emergency department complaining of severe epigastric pain with associated intractable nausea and vomiting. Initial triglycerides were over 1,000. Patient was admitted to the intensive care unit to initiate continuous insulin infusion. On hospital day 2, the patient developed an increase in abdominal pressure as measured by a bladder pressure greater than 37 millimeters of mercury. And as we can see here, this is how we are able to measure the intra-abdominal pressure using an intravesical catheter. Okay, and hers was 37 millimeters of mercury. So patient after that was immediately taken to the emergency, to the OR for surgical decompression via laparotomy, and a womb bag was placed. While in the ICU, the patient returned to the OR multiple times for washouts, and after 3 weeks in the ICU, the patient was extubated. He was also switched from TPN to parenteral feeding and was transferred to the floor. The patient continued to have persistent tachycardia. He continued to have fever, low-grade fevers, leukocytosis, and he was empirically started on broad-spectrum antibiotic and antifungal therapy on and off. She did not have any localized symptoms of an extensive infectious workup for infection was initiated. Blood and urine cultures were always negative. Chest X-ray at bedside revealed a pleural effusion, and thoracentesis was performed. However, the pleural fluid was always negative for infection. The patient went back to the operating room 2 more times for washouts, and no abscess or signs of active abdominal infection was ever found. At this point, with a negative infectious workup, the persistent systemic inflammatory response syndrome was thought to be partially related to the underlying pancreatitis. Patient clinical status continued to improve through the hospital stay, and she was eventually discharged home on stable condition. And on figure 1, we can see this is the CT of the abdomen on the day of admission. And then day 2, that's when she developed the abdominal compartment syndrome. We can see on figure 2 that it's just completely the borders. We're not able to differentiate the pancreas borders. And on figure 3, that's after she had surgery, and that we can see that, if you can see my mouse right here, you can see that that's when she had the wound back placed, and we can see just the inflammation kind of resolved and got a lot better. And by figure 2, that was day 50 of the hospitalization. And my case illustrates the complexity and difficulty of managing patients with acute pancreatitis who develop abdominal compartment syndrome. Patients with this combination have critical elevated rates of mortality and morbidity, but fortunately hers was discovered early and managed promptly. As in this patient, the high metabolic rate secondary to ongoing inflammatory response of the pancreatitis can cause physiologic and systemic idiosyncrasy and does not necessitate treatment for infectious etiologies. Although pancreatitis is one of the most common diagnoses in inpatient medicine, abdominal compartment syndrome must be considered in a deteriorating patient as the line of decompression is extremely thin. Thank you so much for listening, and I'm open for any questions.
Great job, Lena. I wanted to ask, is there any other way to measure abdominal pressure that's less invasive?
Yes. There's the standard method to measure the intra-abdominal pressure is the one that is most used is the intravesical with the catheter. There are other ways that you can, could be like an intracolonic or intragastric, but I think those are even more invasive than the intravesical. So the least invasive would be the intravesical catheter one.
Okay, yeah, I can see how that makes sense. Wonderful job.